Welcome to your practice review for the CCMA certification exam. Every question mirrors the real exam. We break down why the right answer works, why others fail, and the concept behind it. Today's questions cover records and medical law, pharmacology and abbreviations, clinical procedures and phlebotomy, anatomy and physiology, scope of practice and patient safety. Just a reminder, our website offers free exam guides and practice questions designed to help you ace your CCMA exam. You'll find the link right in the description below, so make sure to check it out. It's a smart way to prepare. Study smarter, not harder, and set yourself up for real success. All right, let's jump right in. Question 1. Which of the following best describes typical retention requirements for adult medical records in most states? Your options are A. Often 7 to 10 years after last visit. B. 1 year following the patient's last visit. C. Until the next scheduled annual exam. D. Permanent retention required at every site. Which one is it? Pause the video if you need more time. The correct answer is A. Often 7 to 10 years after last visit. A is correct because while retention varies by state and record type, adult medical records are commonly retained 7 to 10 years after the last visit, with longer requirements for minors, mental health, and certain occupational records. B is wrong because retaining adult records for only 1 year after the last visit conflicts with state laws and CMS expectations, which require multi-year retention to support continuity of care, audits, and statute of limitations protections today. C is wrong because retention until the next scheduled annual exam is unrelated to legal retention rules, which require records to be kept for years after the last visit to support continuity of care in litigation defense today. D is wrong because permanent retention is encouraged for some records such as immunizations, but is not generally required for all adult medical records under typical state and federal retention guidelines applicable in most clinics now. Medical record retention is the set of legal and regulatory rules dictating how long a practice must keep patient health information after care ends, covering paper charts, electronic records, imaging, billing, and consent forms. Retention rules exist because records support continuity of care, document billing for audits, defend practices against malpractice claims, and satisfy public health reporting. Without them, immunization proof, stale claims investigations, and Medicare audits would all be impossible. The retention clock starts at the last date of service for adults, typically running 7 to 10 years. For minors, it starts at the age of majority plus 3 to 7 more years. While mental health and controlled substance records often need even longer, and immunization records are ideally kept permanently. Picture a patient last seen for a sprained ankle in 2017 who files a malpractice claim in 2025. Under a 7 to 10 year retention rule, the chart, imaging, and discharge instructions still exist, letting the practice defend itself. Don't confuse retention with a short operational filing schedule tied to the next physical exam. That's a trap. Also, keep retention separate from destruction, release of information, and breach reporting, since each is its own distinct testing point. Question 2. A medical assistant is destroying paper documents containing PHI. Which of the following methods is most appropriate? Your options are A. Placing the documents in the regular trash. B. Recycling them with general office paper. C. Storing them in an unlocked cabinet. D. Using a crosscut shredder or shred bin. Take a second. Which answer would you pick? The correct answer is D. Using a crosscut shredder or shred bin. D is correct because HIPAA requires reasonable safeguards during disposal of paper PHI, and the recommended method is cross-cut shredding, or use of a contracted shred bin vendor with a business associate agreement and certificate of destruction. A is wrong because placing paper PHI in regular trash is a HIPAA violation that exposes records to unauthorized access and may trigger breach notification requirements when the records leave the practice's control without proper safeguards being in place. B is wrong because recycling with general office paper does not safeguard PHI from unauthorized viewing, may constitute a reportable breach, and is not an approved disposal method under HIPAA's reasonable safeguards or current professional standards today. C is wrong because storing PHI in an unlocked cabinet does not destroy the records and provides no physical safeguard against unauthorized access, which conflicts with HIPAA's physical safeguard requirements under the security rule for storage today. Once a paper record has finished its useful life, HIPAA doesn't just let it go in the trash. Disposal is a controlled, documented event that must prevent anyone from ever reconstructing that patient's information. The rule exists because trash and recycling from medical offices have repeatedly produced confirmed breaches, with patient records recovered from dumpsters. Each incident triggers breach notification, civil penalties, and reputational damage severe enough to close a small practice. There are two approved mechanisms: on-site cross-cut shredding, which slices paper along two axes so nothing can be pieced back together, and a contracted shred vendor who collects locked bins, destroys them at a secure facility, and returns a certificate of destruction. The distinction that trips people up is shred quality. Cross-cut shredders produce tiny confetti that can't be reassembled, while strip-cut shredders leave long ribbons that a determined person could still piece together, falling short of the standard for sensitive content. Any pathway that leaves patient paper readable, even briefly, is the wrong answer. Disposal closes the loop only when destruction is complete and documented. Question 3. A medical assistant restocks samples and finds metoprolol XL alongside metoprolol tartrate. Which of the following describes the XL formulation? Your options are A. Enteric coated, B. buccal route, C. sustained release, D. sublingual. Before I reveal it, which one do you think is right? The correct answer is C. Sustained release. C is correct because XL, ER, and SR formulations are sustained release products designed to release drugs slowly over hours, allowing less frequent daily dosing. Crushing or chewing them ruins the release and can cause dangerous spikes in blood levels. A is wrong because enteric coated describes a coating that resists stomach acid, so the pill dissolves in the intestine, which is a different protective design than the slow release engineering used in extended formulations such as metoprolol XL tablets. B is wrong because buccal route describes placement between cheek and gum, which is a route of mucosal absorption rather than a slow release oral form, and metoprolol XL is taken whole orally rather than dissolved in the cheek pocket at all. D is wrong because sublingual describes a tablet placed under the tongue for rapid mucosal absorption, rather than a slow-release oral product swallowed whole, and metoprolol XL is not designed to dissolve under the tongue for fast onset. Sustained-release tablets and capsules are engineered to release their drug gradually over many hours instead of all at once, letting one dose cover a full dosing interval safely. Many drugs would otherwise need dosing every few hours to stay effective. Frequent dosing hurts adherence and causes sharp peaks and troughs that worsen side effects, so spreading absorption across many hours allows once or twice daily dosing with steadier, safer levels. The mechanism varies. Some tablets use a polymer matrix that erodes slowly, Others use a membrane with a tiny laser-drilled hole, and some capsules contain hundreds of coated beads releasing drug at staggered times. All depend on the tablet or capsule staying intact. Exam writers love this trap. Enteric coatings protect the stomach or drug and dissolve in the intestine, while sublingual and buccal routes are designed for fast onset through the mucosa, not slow release. Only sustained release forms are built to extend duration, so any specially coated pill isn't automatically slow release. Crushing a sustained release tablet destroys its rate-limiting structure and dumps the whole dose at once, causing dangerous dose dumping. Watch for XL, XR, SAR, or CD, and instructions to swallow whole as your cue that duration of release. Not just a special coating is being tested. Question 4. A medical assistant is preparing a tray for a minor in-office surgical excision of a forearm skin lesion. Which of the following sets of equipment is most appropriate? Your options are A. Spirometer, peak flow meter, nebulizer setup. B. Snellen chart, Jaeger card, color plates. C. Doppler, cervical brush, fixative spray. D. Scalpel, sutures, hemostats, retractors. What's your answer? Commit to one before I continue. The correct answer is D. Scalpel, sutures, hemostats, retractors. D is correct because a minor surgery setup includes a scalpel handle and blades, suture material, needle holder, hemostats, tissue forceps, scissors, and retractors. The other groupings belong to vision, pulmonary, and gynecology setups, respectively, for very different exam types. A is wrong because spirometers, peak flow meters, and nebulizers belong in a pulmonary testing area and would not appear on a tray prepared for a small skin excision in the office under local anesthesia today. B is wrong because the Snellen chart, Jaeger card, and color plates belong to a vision testing setup, not the cutting and closing instruments needed to remove and close a small skin lesion during minor surgery. C is wrong because Doppler, cervical brush, and fixative spray belong to obstetric and gynecology exams, not to a general minor surgical excision performed on a forearm skin lesion under local anesthesia in clinic. Setting up a minor surgical tray means deliberately selecting and arranging sterile instruments and supplies for procedures like skin lesion excisions, incision and drainage, ingrown toenail removal, and laceration repair. The medical assistant preps everything in advance so the provider can work efficiently without ever breaking the sterile field. A well-built tray prevents 3 problems at once: contamination of the wound from non-sterile items touching tissue, delays that prolong open wound exposure mid-procedure, and safety errors caused by reaching across the sterile field for missing supplies. Every minor excision tray breaks down into 4 functional groups: cutting tools like the scalpel and scissors, grasping and holding tools like forceps and hemostats, closing tools like sutures and staples, and field tools like drapes, anesthetic, and specimen containers. Picture the tray arranged for a forearm mole excision: cutting tools, grasping tools, closing tools, and field tools all grouped together, so the provider walks in and begins within minutes. Exam writers love to trap you with instruments from other rooms. Spirometers and nebulizers belong to respiratory testing. Snellen charts and Jaeger cards belong to vision stations, and Dopplers or cervical brushes belong to gynecologic exams. Only cutting, grasping, closing, and field tools belong on the skin excision tray. So identify the procedure first, then think through those 4 groups. Question 5. A medical assistant is preparing to obtain consent from a Spanish-speaking patient with limited English proficiency. The patient brought a teenage child to interpret. What should the medical assistant do? Your options are A. Use the teenage child to interpret. B. Have the patient sign anyway. C. Use a qualified medical interpreter. D. Postpone the visit indefinitely. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is C. Use a qualified medical interpreter. C is correct because Title VI and ACA Section 50 MMP7 require qualified medical interpreters for limited English proficient patients. Phone, video, or in-person interpreters protect accuracy and confidentiality. Children should never serve as medical interpreters during a clinical encounter. A is wrong because using minor children as interpreters violates language access standards. Children may misinterpret medical terms, hear inappropriate health information about a parent, and create emotional and ethical concerns for the family during the encounter. B is wrong because consent obtained without true comprehension is not valid consent. Forcing a signature when the patient cannot understand the form fails informed consent requirements and federal language access protections under Title VI of the Civil Rights Act. D is wrong because postponing care indefinitely due to a language barrier is not appropriate. Interpreter services exist precisely so that qualified communication can take place at the time of the planned encounter without delaying necessary patient care. Language access is the legal and ethical duty to provide qualified interpretation for patients with limited English proficiency, so care is understood, not just delivered. This exists because language barriers produce real harm. Patients miss their medication instructions, misunderstand consent forms, fail to disclose symptoms, and skip follow-up care. Federal law treats this as a civil rights issue under Title VI and Section 1557. A clinic relies on three pathways: a phone-based language line for on-demand interpretation, video remote interpreting for sign language and complex consent, and in-person interpreters scheduled for sensitive visits like oncology or end-of-life discussions. Exam writers test this exact trap. Family members, especially minor children, cannot serve as medical interpreters. Children may misinterpret terms, hear distressing prognoses, or feel pressured to soften the truth, while a qualified interpreter is trained in terminology, ethics, and impartial conveyance. Language access is the upstream condition that makes informed consent valid. A signed form means nothing without genuine understanding, delivered through a qualified interpreter, not a relative. Question 6. A provider writes an order for a medication to be given AC. Which of the following is the correct interpretation? Your options are A. Before meals, B. After meals, C. At bedtime, D. As needed. Which would you go with? Lock it in before the reveal. The correct answer is A. Before meals. A is correct because the abbreviation AC comes from the Latin ante cibum and means before meals. After meals is PC, at bedtime is HS, and as needed is PRN. Many medications require pre-meal dosing for proper absorption. B is wrong because after meals corresponds to the abbreviation PC, past cibum, and is the opposite timing from what the order specified, which would change drug absorption profiles and could affect therapeutic outcome for medications dependent on stomach contents. C is wrong because at bedtime corresponds to the abbreviation HS, ora somni, and refers to nighttime dosing rather than dosing tied to meals during the day, which would deliver medication at an entirely different point in the daily routine. D is wrong because as needed corresponds to the abbreviation PRN, prorenata, and means dosing only when symptoms occur rather than at a meal-related time. So the dosing pattern would not match the actual order written by the provider. Medical abbreviations for dosing schedules come from Latin, and providers rely on them to write fast, precise orders. But timing matters as much as dose, so a medical assistant must translate them correctly every time. The abbreviation AC comes from anti-Sibum, meaning before meals. PC comes from post-Sibum, meaning after meals. This comes from hora somni, meaning at bedtime. And PRN comes from pro renata, meaning as needed for the listed indication. Consider levothyroxine ordered AC daily. Taken on an empty stomach 30 to 60 minutes before breakfast. The hormone absorbs fully. Taken with food instead. Calcium and food block absorption, leaving thyroid levels subtherapeutic even though the prescription was filled correctly. Don't confuse timing abbreviations with root abbreviations like PO, E, V, and SQ, which describe how a drug enters the body, or frequency abbreviations like Q4H. Each category has its own Latin root and its own job in a complete order. When a question tests AC versus PSA, slow down and anchor back to the Latin. Antisibum before, post-sibum after. That single letter difference can change how much drug actually reaches the bloodstream. Question 7. A patient calls a medical assistant and asks what dose of her blood pressure medication she should take today. Which of the following is the most appropriate response? Your options are A. Suggest a dose based on her chart. B. Look up the dose in a drug guide. C. Refer the question to the provider. D. Tell her to use her judgment. Don't overthink it. Which one feels right? The correct answer is C. Refer the question to the provider. C is correct because determining or recommending a dose is prescribing, which falls outside the medical assistant's scope of practice. Routing the question to a licensed provider keeps the patient safe and protects the assistant from a scope violation. A is wrong because suggesting a dose based on the chart is prescribing, which the medical assistant cannot perform under any state scope of practice and which providers cannot legally delegate to unlicensed staff for any patient. B is wrong because looking up a dose still places the medical assistant in the role of selecting therapy, which is a prescribing decision that no drug reference can authorize unlicensed staff to make for an individual patient at home. D is wrong because telling the patient to use her own judgment abandons the duty to involve the prescriber and exposes her to harm from an unsafe dose chosen without any clinical training or oversight by licensed personnel. Scope of practice is the legal boundary around what an unlicensed medical assistant may do under a provider's delegation. It varies by state, but it always excludes diagnosing, prescribing, adjusting dosages, interpreting results, and triaging outside written protocols. The medical assistant works under the supervising provider's license, and that license is what authorizes any delegated task. Letting unlicensed staff make therapeutic calls creates real patient harm and legal liability. So boards draw a firm line. In daily practice, providers delegate rooming, vital signs, medication administration after an order, point of care testing, and patient education from approved handouts. What they never delegate is prescribing, dosage selection, or independent counseling on therapy. Picture a patient calling about her lisinopril after a low blood pressure reading, asking whether to skip today's dose. The medical assistant documents the concern and routes it to the provider, who decides, and the assistant relays and charts the provider's answer. Watch for STEM language like recommend, suggest a dose, or interpret results. These signal a decision that belongs to the provider. The medical assistant's job is to route and document, not to decide. Question 8. A medical assistant administers a vaccine to the wrong patient. Which of the following actions should the medical assistant take first? Your options are A. Notify the provider and complete an incident report. B. Document the error in the incident report only. C. Reference the incident report in the chart. D. Wait until the next shift to report. Got a guess? Lock it in. The correct answer is A. Notify the provider and complete an incident report. A is correct because medication errors require immediate notification of the provider to assess the patient and then completion of an incident report kept separate from the medical record, supporting both patient safety and risk management. B is wrong because documenting only without notifying the provider delays patient assessment, may miss an adverse reaction, and fails the immediate clinical response required when a medication error reaches the patient in the office. C is wrong because referencing the incident report in the chart is incorrect, because incident reports are kept separate from the medical record as quality improvement documents protected from discovery in many states under current law. D is wrong because waiting until the next shift delays patient assessment, may worsen any reaction, and violates incident reporting expectations that require completion as soon as possible after the event has occurred during care. When a medication error reaches a patient, there's a specific order of operations that keeps patients safe and protects the practice legally. Let's break down exactly how it works. First, the staff member who discovers the error notifies the provider immediately so the patient can be assessed. Second, they complete an incident report capturing who, what, when, where, and how. Third, the chart documents the clinical event and treatment but never mentions the incident report. These two documents stay completely separate. The chart holds the clinical facts and treatment. The incident report holds the workflow details, filed in the risk management file, protected from legal discovery as long as it's never referenced inside the chart. The traps are predictable: jumping to paperwork before notifying the provider, mentioning the incident report inside the chart and waiving its legal protection, delaying the report so the patient leaves unassessed, or confusing this process with MedWatch, which reports drug safety rather than workflow errors. Notify the provider first, file the incident report separately, and keep it out of the chart. That order protects the patient and the practice. Question 9. Which small airway structures narrow during an asthma attack, producing wheezing and dyspnea? Your options are A. Alveoli, B. Pleura, C. Pharynx, D. Bronchioles. Which one is it? Pause the video if you need more time. The correct answer is D. Bronchioles. D is correct because bronchioles are small airways that branch from the bronchi and lead to the alveoli. In asthma, smooth muscle in bronchial walls constricts and inflames, narrowing the airways and producing wheezing and dyspnea. A is wrong because alveoli are tiny air sacs at the end of the respiratory tree where gas exchange occurs, so they do not constrict like the smooth-muscled smaller airways that narrow during an asthma attack. B is wrong because pleura are serous membranes covering the lungs and lining the thoracic cavity, so they are not the small smooth-muscled airways that constrict during an asthma exacerbation in a wheezing patient. C is wrong because pharynx is the throat above the larynx that serves as a passage for both air and food, so it is not part of the smaller smooth-muscled airways that narrow during asthma attacks. Air travels through a branching system of airways called the respiratory tree, narrowing at each level until it reaches the alveoli where gas exchange happens. The tree begins at the nose and pharynx, passes through the larynx and trachea, splits at the carina into the main bronchi, and keeps dividing into smaller bronchioles until it reaches the alveoli. Bronchioles are the smallest airways, and their walls contain smooth muscle whose tone decides whether air reaches the alveoli. Beta-2 receptors relax that muscle and open the airway, while cholinergic signals and inflammatory mediators contract it and narrow the passage. Exam distractors love to substitute other structures, alveoli are gas exchange sacs with no smooth muscle. Pleura are the serous membranes around the lungs. And the pharynx is just the upper throat. None of these constrict the way bronchioles do in an asthma attack. Whenever a stem describes wheezing from narrowed small airways, think bronchiole and its smooth muscle wall, not alveoli, pleura, or pharynx. Question 10. Which structures within the lungs are the primary site of gas exchange between blood and inspired air? Your options are A. Bronchi, B. Trachea, C. Alveoli, D. Larynx. Take a second. Which answer would you pick? The correct answer is C. Alveoli. C is correct because alveoli are tiny grape-like air sacs at the end of the respiratory tree. Their thin walls and surrounding pulmonary capillaries allow oxygen and carbon dioxide to diffuse rapidly between inspired air and circulating blood. A is wrong because bronchi are larger conducting airways that branch from the trachea and direct air toward the lungs, so they are not the actual sites of gas exchange between blood and inspired air described. B is wrong because trachea is the windpipe conducting air from the larynx to the main bronchi, so it is part of the conducting zone rather than the respiratory zone where gas exchange occurs in the lungs. D is wrong because larynx contains the vocal cords and lies above the trachea in the upper airway, so it is part of the conducting zone rather than the gas exchange surface of the lower respiratory tract. Deep in the lungs, roughly 300 million tiny air sacs called alveoli provide a surface area as large as a tennis court. This is where oxygen enters the blood and carbon dioxide leaves it. 3 structural features make this possible. Type 1 pneumocytes form a thin, flat wall ideal for diffusion. Type 2 pneumocytes secrete surfactant to prevent collapse, and the capillary endothelium fuses tightly against the alveolar wall to shrink the diffusion distance. Exam writers love this distinction. The conducting zone, including the trachea and bronchi, only moves air. The respiratory zone, including respiratory bronchioles and alveoli, is where gases actually cross into and out of the blood. In pneumonia, fluid and white blood cells fill the alveoli, blocking oxygen from reaching the capillaries and causing hypoxia. Clearing that fluid with antibiotics and oxygen restores diffusion and normal saturation. Whenever a question describes actual gas transfer between air and blood, think alveolus, not the airways that merely carry air. Question 11. Which of the following needs sits at the foundation of Maslow's hierarchy and must be met first? Your options are A. Self-actualization, B. Esteem from others, C. Love and belonging, D. Physiological needs. Before I reveal it, which one do you think is right? The correct answer is D. Physiological needs. D is correct because Maslow's hierarchy places physiological needs such as food, water, and air at the base. These must be met before safety, belonging, esteem, or self-actualization can be addressed effectively. The framework helps medical assistants prioritize patient interventions during care. A is wrong because self-actualization sits at the very top of Maslow's hierarchy and depends on all lower levels first being satisfied, so it cannot be the foundation that supports the pyramid in patient care or any other application of the model. B is wrong because esteem from others falls in the upper middle of the hierarchy and depends on physiological, safety, and belonging needs being met first, so it cannot be the foundation that the pyramid rests on for any patient case. C is wrong because love and belonging falls in the middle of the hierarchy and depends on physiological and safety needs being met first, so it cannot serve as the foundation of the pyramid in either theory or practical patient care today. Clinics have a legal and ethical duty to provide effective communication for patients whose primary language is not English. This duty flows from federal law and protects against decades of documented harm caused by language barriers. The framework rests on Title VI of the Civil Rights Act and Section 1557 of the Affordable Care Act. Any clinic accepting Medicare or Medicaid falls under this umbrella, meaning qualified interpreter services must be provided at no cost to the patient. A qualified medical interpreter is trained in clinical terminology, confidentiality, and interpreting technique, whether delivered by phone, video, or in person. A bilingual staff member only counts if formally tested and trained, since casual fluency cannot explain anticoagulation or oncology consent. Picture a Spanish-speaking patient bringing her teenage daughter to interpret for a procedure consent. This creates three problems at once. The consent becomes legally questionable, the minor is exposed to sensitive clinical content, and the clinic steps outside federal language access law. Minors must never interpret except in true emergencies, and even adult family members may only step in if the patient declines a qualified interpreter after being offered one. The right answer is always the same: decline politely and connect the patient to a credentialed interpreter. Question 12. A medical assistant reviews male reproductive physiology with a learner. Which specific cells within the testes are responsible for producing testosterone? Your options are A. Sertoli cells, B. Spermatogonia, C. Leydig cells, D. Cowper gland cells. What's your answer? Commit to one before I continue. The correct answer is C. Leydig cells. C is correct because Leydig cells in the interstitial tissue between the seminiferous tubules of the testes produce testosterone in response to luteinizing hormone. Testosterone drives male secondary sexual characteristics, spermatogenesis, libido, and muscle development. A is wrong because Sertoli cells line the seminiferous tubules and support spermatogenesis by providing nutrients to developing sperm, but they do not produce testosterone, which is synthesized by neighboring Leydig cells in the testes. B is wrong because spermatogonia are the diploid germ cells that divide and mature into spermatozoa within the seminiferous tubules, so they are not the testosterone-producing cells described in this male reproductive endocrine question. D is wrong because Cowper gland cells produce a clear pre-ejaculate fluid that lubricates the urethra during sexual arousal, so they are not the testosterone-producing cells located within the testes described in this question. Pharmacy abbreviations are Latin-rooted shorthand that tells providers and patients exactly when to take a medication relative to meals or sleep. Getting them right isn't trivia. It directly affects how well a drug is absorbed. AC comes from ante cibum, meaning before food. PC comes from post cibum, meaning after food. Schiz, hora somni, means at bedtime, and pia and pro renata means as needed when symptoms occur. The distinction exists because of pharmacokinetics, how the body absorbs, distributes, and eliminates a drug. Food changes stomach pH and slows transit, and it can even bind to certain medications, so whether you eat first genuinely changes how much drug reaches your bloodstream. Consider a Lendronate taken once weekly AC on an empty stomach with plain water, it absorbs well. But if mistaken for PC and taken after breakfast, calcium in food binds the drug and most of it passes through unabsorbed, wasting the dose entirely. AC is before, PC is after, HS is bedtime, and PRN is as symptoms demand. Silently translating the Latin root before answering protects you from costly mix-ups on exam day and in practice. Question 13. A medical assistant notices that a centrifuge serum specimen appears milky and turbid above the clot. Which of the following findings is most likely? Your options are A. Hemolysis, B. Icterus, C. contamination, D. lipemia. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is D. Lipemia. D is correct because A. turbid, milky appearance indicates lipemia, usually from a non-fasting draw or hypertriglyceridemia. Hemolysis tints serum pink. Icterus turns a deep yellow from bilirubin. And contamination causes biochemical errors without producing a milky look in the tube. A is wrong because hemolysis tints serum pink to red because of free hemoglobin released from ruptured cells, not the milky white turbidity caused by elevated lipid particles in plasma during fasting violations or hypertriglyceridemia in patients. B is wrong because icterus produces a deep yellow appearance reflecting elevated bilirubin levels and looks distinct from the cloudy white of lipemia, which is generated by chylomicrons and very low-density lipoprotein particles instead in tube samples. C is wrong because EDTA contamination from drawing tubes out of order affects results chemically without producing the visual milkier cloudiness associated with elevated lipid particles in plasma after a non-fasting collection performed earlier today. Scope of practice is the legal line that defines what a credentialed worker may and may not do under state law and the supervising provider's delegation. For unlicensed clinical staff, prescribing sits firmly outside that line in every state. Prescribing means selecting a drug, choosing a dose, choosing a route, and choosing a frequency for a specific patient. Recommending a dose over the phone counts as prescribing, whether the staffer reads from a chart, a drug guide, or memory. Delegation flows from the licensed provider downstream, but only for tasks state law permits. Prescribing decisions sit at the top of every list of non-delegable tasks published by state medical and nursing boards. When a patient calls asking whether to take 25 or 50 milligrams of metoprolol, the correct workflow is to document the call, route it to the licensed provider or triage nurse, and escalate immediately if symptoms like chest pain or dizziness suggest urgency. Suggesting a dose, looking it up in a guide, or telling a patient to use her own judgment or cross the line. Routing the call to a licensed provider keeps the patient safe and keeps the staffer inside scope. Question 14. A patient asks whether step therapy means trying less expensive medications before a costly biologic is approved. Which of the following best describes step therapy? Your options are A. Step therapy bypasses prior authorization. B. Step therapy means immediate brand approval. C. The insurer requires trial of cheaper options. D. The insurer pays without documentation. Which would you go with? Lock it in before the reveal. The correct answer is C. The insurer requires trial of cheaper options. C is correct because step therapy requires the patient to try and fail less expensive medication options before the insurer approves a costlier therapy. Documentation of prior trials, intolerances, or contraindications is necessary to obtain approval for the biologic through prior authorization. A is wrong because step therapy is part of the prior authorization process rather than a bypass of it. Insurers use step therapy to control costs while ensuring patients receive appropriate evidence-based care progression first before more expensive medications are approved. B is wrong because step therapy specifically delays brain approval until cheaper options are tried first. The patient must work through preferred therapies first, with documented results, before more expensive medications are approved by insurers through the prior authorization process. D is wrong because insurers require documentation of medical necessity prior trials, and clinical justification for specialty medications. They do not pay for biologics without supporting records, even after step therapy has been satisfied, and require complete documentation before approval. When a medication reaches the wrong patient, everything hinges on doing things in the right order. Patient safety doctrine and accreditation standards fix that sequence for a reason. Harm reduction research shows the first hour after an error is the most critical time to act. Notifying the provider immediately lets them assess for allergic reaction, drug interactions, contraindications, and the need for monitoring before that window closes. The correct order is stop, assess, notify the provider, monitor the patient, document clinical facts in the chart, then complete the incident report separately, followed by disclosure as the provider directs. Skipping notification to do paperwork first inverts this order and risks missing a deteriorating patient. The clinical chart holds what was given, when, and the patient's status. The incident report, a separate quality and risk document, is never referenced inside the chart, because linking them could strip away its legal protection under peer review statutes. Notify the provider and stay with the patient before anything else. Then document clinical facts in the chart and complete the incident report on its own separate form. That order protects the patient and preserves the integrity of quality improvement. Question 15. A medical assistant is coordinating care for a homebound patient who needs intermittent skilled nursing visits and physical therapy at home. Which of the following clinical resources is most appropriate? Your options are A. Skilled nursing facility placement, B. Home health care services, C. Hospice end-of-life care, D. Inpatient rehabilitation hospital. Don't overthink it. Which one feels right? The correct answer is B. Home health care services. B is correct because home health delivers skilled nursing, physical therapy, occupational therapy, and aid services to homebound patients with intermittent skilled needs under physician orders. It often follows hospitalization to support recovery and prevent avoidable readmission. A is wrong because a skilled nursing facility provides short-term inpatient rehab after a qualifying hospital stay. The patient lives at the facility rather than receiving care at home, which does not match this homebound patient's situation or preference. C is wrong because hospice serves patients with a prognosis of 6 months or less and focuses on comfort rather than recovery. It is not appropriate for a patient who needs skilled nursing and rehabilitation following hip surgery to regain function. D is wrong because inpatient rehab requires 3 or more hours of intensive therapy daily and admission to a facility. It is not the appropriate resource for occasional skilled visits delivered at home for a recovering post-surgical patient who is homebound. Bronchioles are the smallest conducting airways, and unlike bigger bronchi, their walls have almost no cartilage. Instead, they are ringed by smooth muscle under autonomic control, which is exactly why they can constrict so powerfully. Picture air trying to pass through a flexible drinking straw. Now squeeze that straw with a fist of smooth muscle, swell the lining, and add a sticky mucus plug, and air can barely get through, especially on exhale when chest pressure squeezes the narrowed tube even more. Triggers like allergens, cold air, or smoke cause mast cells to release histamine and leukotrienes, driving smooth muscle contraction, mucosal edema, and mucus plugging all at once. That narrows the lumen right, where airflow resistance is already highest, producing wheeze and dyspnea. Exam questions love to test this distinction. Alveoli exchange gas but don't constrict. The pleura isn't an airway at all, and the pharynx and trachea are upper airway structures, not the smooth muscled bronchioles that wheeze in classic asthma. Bronchodilators relax that smooth muscle, steroids calm the inflammation, and mucolytics clear the plug, but all of them target the bronchiole, Recognizing that is the key to both the correct test answer and correct bedside reasoning. Question 16. A medical assistant notices that a referral was sent to cardiology 3 weeks ago and no consult note has returned. The patient confirms attending the appointment. What should the medical assistant do next? Your options are A. Close the referral as complete. B. Discharge the patient from the practice. C. Cancel the original referral order. D. Contact the cardiology office. Got a guess? Lock it in! The correct answer is D. Contact the cardiology office. D is correct because closed-loop referrals require receipt of the consult note. The medical assistant should contact the specialist's office to request the note, document the follow-up, and ensure the provider can review the recommendations during the next encounter. A is wrong because closing the loop requires receipt of the consult note rather than confirmation of an appointment kept by the patient. Without the report, the referring provider cannot review findings or coordinate next steps in the plan of care. B is wrong because discharging the patient is unrelated to a missing consult note from the specialist. The patient continues care at the primary care practice, and the referral loop must be closed through document retrieval rather than through patient discharge. C is wrong because cancelling a referral the patient already attended creates documentation gaps and may interfere with billing for the specialist. The visit took place, and the missing piece is the consult report rather than the referral order to be cancelled. Deep in the lungs are roughly 300 million tiny air sacs called alveoli, each wrapped in a dense mesh of pulmonary capillaries. Their walls are only half a micrometer thick, and together they provide about 70 square meters of surface area, making the alveolus the body's true site of gas exchange. Oxygen and carbon dioxide move by simple diffusion, from high partial pressure to low partial pressure. Fresh alveolar air is rich in oxygen and low in carbon dioxide, while incoming venous blood is the opposite. So oxygen diffuses into the capillaries and carbon dioxide diffuses out into the alveolus. It's crucial to separate the conducting zone from the respiratory zone. The trachea, bronchi, and most bronchioles only channel and condition air. Only the respiratory bronchioles and alveoli have the thin walls and capillary contact needed for actual gas exchange. In emphysema, chronic smoking destroys alveolar walls, merging small sacs into larger ones with far less surface area for diffusion, which leaves patients hypoxemic and breathless, and no drug can rebuild what's lost. Whenever an exam asks where gas exchange occurs, the answer is the alveolus, supported by surfactant that keeps it from collapsing, making this one of the highest yield facts in respiratory anatomy. Question 17. A new patient tells the medical assistant during intake that he uses he, him pronouns even though his legal records list a female name. Which of the following actions should the medical assistant take? Your options are A. Demand a legal name change first. B. Ignore the patient's stated preference. C. Document chosen name and pronouns. D. Inform other staff of the history. Which one is it? Pause the video if you need more time. The correct answer is C. Document chosen name and pronouns. C is correct because best practice is to document chosen name and pronouns in the EHR, so all staff use them consistently while keeping the legal name in its appropriate field to protect privacy and dignity. A is wrong because demanding a legal name change creates an unnecessary barrier, disrespects the patient, and is not required by HIPAA, ACA Section 1557, or any clinic intake policy in current professional practice. B is wrong because ignoring stated pronouns violates inclusive communication standards and ACA Section 1557 protections. damages trust between the patient and the team, and contradicts current EHR documentation expectations clearly today. D is wrong because disclosing gender history to co-workers without consent breaches confidentiality, harms the patient emotionally, and may violate state non-discrimination laws and the clinic's privacy policy entirely in this case. Abraham Maslow's 1943 framework arranges human needs into a pyramid of 5 tiers, and it gives clinicians a tool for deciding what to address first when many problems compete for attention. From base to peak, physiological needs like food, water, and sleep, safety, covering body, employment, and health, love and belonging, esteem, both self and from others, and self-actualization, the realization of personal potential at the very top. Picture the needs stacked as a pyramid. The base must be secured before the team can effectively work upward, because effort spent on higher needs while the foundation is unmet tends to fail. In clinical care, before discussing medication adherence or lifestyle change, the team must confirm the patient is housed, fed, and safe, social determinants of health screening, food pantry referrals, and housing resources are simply Maslow's base tier translated into checklist form. On exams and in practice, a hungry, cold, or dehydrated patient always points to the physiological tier as the priority, no matter how urgent the higher tier concerns may seem. Question 18. A patient says, "I just want to give up." Which of the following is the most therapeutic response by the medical assistant? Your options are: A. Don't say that, things will improve. B. Why would you feel that way today? Say, let me get the doctor immediately now. D. It sounds like you feel hopeless. Take a second, which answer would you pick? The correct answer is D. It sounds like you feel hopeless. D is correct because reflecting the patient's feeling validates the emotion, demonstrates active listening, and opens space for further disclosure, which is consistent with therapeutic communication techniques used to address emotional distress in patients. A is wrong because false reassurance such as "things will improve" dismisses the patient's feelings, blocks therapeutic dialogue, and is listed among non-therapeutic responses that medical assistants should avoid in clinical communication with patients. B is wrong because why questions can sound accusatory, place the patient on the defensive, and discourage further disclosure rather than gently inviting the patient to share more about the underlying feelings present in the moment. C is wrong because immediately leaving to get the doctor abandons the patient in a moment of emotional vulnerability, missing an opportunity to apply therapeutic communication and offer presence before involving the provider in the situation. Inside each testis, 2 structures work side by side: seminiferous tubules where sperm mature, and the interstitial tissue between them, home to the Leydig cells. Leydig cells are the testis's endocrine engine, producing roughly 95% of the body's testosterone. Picture the testis in cross-section, called seminiferous tubules lined by Sertoli cells, which nurture developing sperm, and in the spaces between tubules, the Leydig cells, which manufacture testosterone. The hypothalamic pituitary gonadal axis controls this system. The hypothalamus releases GnRH. The pituitary responds with LH and FSH, and LH binds Leydig cells to trigger testosterone synthesis, while FSH supports Sertoli cells. Exam traps hinge on telling these apart. Leydig cells secrete testosterone. Sertoli cells nurture sperm. Spermatogonia divide to form sperm, and Cowper glands produce lubricating pre-ejaculate fluid. Low testosterone with elevated LH points to primary hypergonadism, meaning the Leydig cells themselves are failing despite full pituitary drive. When a question asks about the source of testosterone, the answer is Leydig cells. When it asks about nurturing sperm, the answer shifts to Sertoli cells. Question 19. A medical assistant is placing precordial electrode V1 during a 12-lead EKG. Which of the following landmarks is correct? Your options are A. Fifth intercostal space, midclavicular line. B. Anterior axillary line at V4 horizontal level. C. Fourth intercostal space, right sternal border. D. Midway between V2 and V4. Before I reveal it, which one do you think is right? The correct answer is C. Fourth intercostal space, right sternal border. C is correct because V1 sits in the fourth intercostal space just right of the sternum. V2 mirrors it on the left. V4 sits at the fifth intercostal space midclavicular and V5 at the anterior axillary line. A is wrong because the fifth intercostal space at the midclavicular line corresponds to V4, not V1, in the precordial lead set used during a standard 12-lead electrocardiogram on an adult patient at the visit today. B is wrong because the anterior axillary line at the V4 horizontal level corresponds to V5, not V1, and is one of the lateral chest electrodes added after the septal and apical leads have been placed during recording. D is wrong because midway between V2 and V4 is the V3 position, used to bridge the septal and apical chest views during a 12-lead recording rather than to anchor the right-sided V1 view at all today. Before a lab result ever gets reported, a sharp-eyed technician reads the specimen itself. Serum and plasma can tell you something is wrong just by their color and clarity, long before the analyzer runs. Lipemia happens because triglyceride-rich particles like chylomicrons and very low-density lipoprotein scatter light as it passes through the tube. This turns serum cloudy or milky, and it shows up transiently after eating, or persistently in conditions like hypertriglyceridemia, poorly controlled diabetes, or heavy alcohol use. The three classic interferences each have a signature look. Hemolysis tints serum pink to red from spilled hemoglobin. Icterus turns a deep yellow to greenish from bilirubin. And lipemia produces a milky white turbidity that looks like neither. Recognizing lipemia matters because it actively distorts results. It scatters light in spectrophotometric assays. It displaces plasma water, causing pseudohyponatremia, and it can even trick hematology analyzers into misclassifying white cells. A milky, opaque tube should always be flagged as lipemic, with fasting status documented and recollection arranged, rather than reported blindly. Confident visual recognition of color is the fastest route to a trustworthy lab result. Question 20. A strict vegan reports tingling in her feet, fatigue, and macrocytic anemia on lab work. Which of the following nutrient deficiencies is the most likely cause? Your options are A. Vitamin C, B. Vitamin D, C. Vitamin A, D. Vitamin B12. What's your answer? Commit to one before I continue. The correct answer is D, vitamin B12. D is correct because vitamin B12 is found primarily in animal foods, so strict vegans risk deficiency as body stores deplete. Symptoms include macrocytic anemia and neurologic findings such as tingling and weakness. Supplements or fortified foods address this nutritional gap. A is wrong because vitamin C deficiency causes scurvy with bleeding gums, poor wound healing, and bruising rather than macrocytic anemia and neurologic tingling, so it does not match the laboratory findings and symptom pattern described, in this case carefully. B is wrong because vitamin D deficiency causes osteomalacia or rickets with bone softening and pain rather than macrocytic anemia with neuropathy, so it does not match the clinical picture of fatigue, tingling, and large red blood cells described in labs. C is wrong because vitamin A deficiency causes night blindness and eventually xerophthalmia in severe cases, and it does not produce the macrocytic anemia and neurologic picture described. So the deficiency does not fit this presentation in the patient today. Step therapy is a cost control tool insurers use to make sure cheaper medications are tried before expensive ones are approved. Picture a formulary ladder. The patient starts on a low, cheap rung and only steps up when that rung fails, documenting each attempt along the way until they finally reach the costly specialty drug at the top. Consider a patient with rheumatoid arthritis whose methotrexate alone isn't working. Before the biologic adalimumab is approved, the clinic must document a 3-month methotrexate trial, a second conventional DMARD trial, and supporting chart notes, fill histories, and disease scores submitted through prior authorization. Step therapy is easy to confuse with related tools. Prior authorization is the umbrella process confirming medical necessity. Step therapy is one specific criterion within it. Quantity limits cap doses per month, and formulary tiers set patient cost share. Remember, step therapy is a form of prior authorization, not an alternative to it. And even after all steps are satisfied, documented medical necessity still must be on file before the biologic is approved. Question 21. A practice is participating in HEDIS reporting. Which of the following rooming activities most directly supports performance on common quality measures? Your options are A. Reconciling medications and documenting screenings. B. Ordering specialist consults independently. C. Diagnosing new chronic conditions. D. Submitting claims to clearinghouses. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is A. Reconciling medications and documenting screenings. A is correct because medication reconciliation, depression screening, smoking status, and BMI documentation are routine medical assistant tasks that directly feed HEDIS and MIPS measures. These rooming activities help close care gaps and capture quality measure credit. B is wrong because ordering specialist consults independently is outside the medical assistant's scope of practice. Providers must initiate referrals, although the medical assistant can complete the paperwork and coordinate the referral process after the order is placed. C is wrong because diagnosing new chronic conditions requires a licensed clinician. Medical assistants assist with rooming, history collection, and care gap identification rather than independent diagnostic decisions, which fall within the provider's scope of practice exclusively. D is wrong because claim submission is handled by billing or revenue cycle staff, not by rooming medical assistants. Rooming medical assistants focus on direct patient care activities that influence quality measure performance rather than on back-end claim processing. Quality measurement programs turn clinical care into reportable numbers, and the rooming workflow is where most of that data gets captured. Programs like HEDIS and MIPS tie payment and performance scores to structured data entered before the provider ever walks in. Quality reporting exists because old fee-for-service models rewarded seeing patients, not documenting outcomes. Now practices lose real revenue when blood pressure, smoking status, or a depression screen goes unrecorded. So closing these gaps during rooming is faster and cheaper than chasing them down later. The mechanism behind all of this is the discrete data field, since free text notes can't be reliably parsed by reporting engines. Rooming activities that feed quality measures include medication reconciliation, vitals and BMA, depression screening, smoking status, immunization history, and standing order vaccinations. Picture a chronic care visit where the medical assistant notices an overdue A1C, a missing flu shot, and no depression screen on file. By running the PHQ-2, flagging the vaccine for a standing order, and updating the record, 3 care gaps close before the provider even opens the door. Exam questions test this boundary. Allergy verification and full risk screening belong to rooming, while independent diagnosis and claim submission belong to providers and billing staff. Rooming sits between registration and provider assessment, exactly where the medical assistant has the biggest direct impact on quality measure performance. Question 22. Under HIPAA, which of the following disclosures may be made without the patient's authorization? Your options are A. Marketing to the patient's employer, B. Sale of records to an outside vendor, C. Treatment, payment, or healthcare operations, D. Sharing PHI with the patient's neighbor. Which would you go with? Lock it in before the reveal. The correct answer is C. Treatment, payment, or healthcare operations. C is correct because HIPAA permits disclosures for treatment, payment, and healthcare operations without specific patient authorization, while marketing, sale of PHI, and most other non-routine disclosures require a written, signed authorization from the patient. A is wrong because marketing to the patient's employer requires written authorization under HIPAA because it falls outside treatment, payment, and operations and triggers the rule-specific authorization requirements for non-routine disclosures of PHI today. B is wrong because sale of records is a non-routine disclosure that requires specific written authorization from the patient under HIPAA and may also trigger additional requirements under high-tech and state law for valid consent today. D is wrong because sharing with a neighbor is not permitted without authorization unless the patient has specifically designated that person as an authorized recipient of certain information through a written release on file at office. HIPAA sets the federal floor for protecting patient health information, and one of its most tested rules is knowing exactly when disclosure requires patient authorization. Covered entities can freely use and disclose protected health information for 3 routine purposes, abbreviated TPO treatment, payment, and healthcare operations. Almost anything outside this triad requires a signed authorization. Picture a practice faxing lab results to a consulting endocrinologist versus a marketing firm asking for a list of diabetic patients. The fax falls under treatment and needs no authorization, but releasing patient names for marketing violates the privacy rule. Watch for disclosures that look routine but aren't: marketing communications, sale of health information, psychotherapy notes, and releases to employers, schools, or third parties with no clinical relationship. These almost always demand explicit authorization. Treatment, payment, and healthcare operations form the umbrella, covering routine practice activity. Anything falling outside that umbrella needs an explicit signed authorization on file. Question 23. Which of the following describes a primary purpose of the Genetic Information Non-Discrimination Act? Your options are A. Regulate prescribing of controlled substances tightly. B. Prohibit genetic discrimination in insurance and employment. C. Require advanced directive education at hospitals. D. Mandate accessible facilities for disabled patients. Don't overthink it. Which one feels right? The correct answer is B. Prohibit genetic discrimination in insurance and employment. B is correct because the Genetic Information Non-Discrimination Act prohibits discrimination based on genetic information in health insurance and employment, protecting patients who may otherwise hesitate to undergo genetic testing because of these specific employment concerns. A is wrong because regulating controlled substances is the role of the Controlled Substances Act, which establishes schedules and DEA registration requirements, not the Genetic Information Non-Discrimination Act used in clinical and employment settings today. C is wrong because advanced directive education at facilities receiving Medicare or Medicaid is required by the Patient Self-Determination Act, not by the Genetic Information Non-Discrimination Act, which addresses genetic privacy rather than directives. D is wrong because accessibility for disabled patients is required by the Americans with Disabilities Act, which addresses reasonable accommodations and accessible facilities rather than genetic information protections under federal employment and insurance law today. As genetic testing became routine in primary care, Congress passed GINA in 2008 to stop genetic information from being used against patients. It protects people in two specific arenas: health insurance and employment. Title I bars health plans from using genetic information to set eligibility, premiums, or coverage. Title II bars employers with 15 or more workers from using it in hiring, firing, or promotion. Even family medical history counts as genetic information under the law. Picture a woman with a family history of ovarian cancer who avoids BRCA testing, out of fear it could raise her premiums or cost her a promotion. GINA removes that fear by blocking insurers and employers from using pre-symptomatic genetic information, so patients can pursue testing and prevention without penalty. GINA has real gaps. It does not cover life, long-term care, or disability insurance, nor military members or employers with fewer than 15 workers. And once a genetic condition has actually manifested, protection shifts to the Americans with Disabilities Act instead of GINA. Remember the contrast. HIPAA controls confidentiality of health data, while GINA controls discrimination by insurers and employers. Whenever a question centers on genetic testing and coverage or hiring bias, GINA is the answer. Question 24. A medical assistant reaches a patient's voicemail when calling about a follow-up appointment. Which of the following messages best follows HIPAA minimum necessary guidance? Your options are: A. Recite the recent lab results clearly. B. Discuss the diagnosis with whoever listens. C. Leave practice name and a callback request. D. Hang up without identifying the practice. Got a guess? Lock it in. The correct answer is C. Leave practice name and a callback request. C is correct because HIPAA minimum necessary principles allow leaving the practice name and a callback request. But specific clinical details should not be left on voicemail unless the patient has authorized that level of disclosure. A is wrong because reciting lab results on voicemail discloses PHI to anyone with voicemail access, violates the minimum necessary standard, and risks a reportable HIPAA breach against the medical practice that placed the call today. B is wrong because discussing the diagnosis with whoever listens skips identity verification, breaks confidentiality, and may disclose protected information to an unauthorized household member or visitor without the patient's authorization on file currently. D is wrong because hanging up without identifying the practice fails to give the patient any way to respond to the message and reflects poor telephone etiquette in the clinical office setting under current professional standards today. Voicemail is risky because once a message is left, the practice loses control over who actually hears it. That's why HIPAA's minimum necessary standard requires voicemail messages to carry only the smallest amount of information needed, which is almost always just a request to call back. Because voicemail boxes are shared, a spouse, child, roommate, or co-worker might be the one who actually hears the message, leaving a lab result, diagnosis, or medication name on that recording discloses it to whoever listens. And that can trigger a reportable breach under HIPAA and high-tech. Picture a medical assistant calling a cardiology patient on a Friday afternoon. A compliant message names the practice, gives a callback number, and asks for a return call about an appointment matter. A non-compliant message reads off the appointment time, the cardiologist's name, the diagnosis, and the blood pressure reading, exposing all of it to anyone who picks up the phone. Patients also have the right to request alternative means or locations of communication, like calling only a cell phone, avoiding the home number, speaking only to the patient, or skipping voicemail entirely. The practice must honor reasonable request, document them in the chart, and make sure front desk and rooming staff can see the note before placing any call. Compare this to secure patient portals, which use authenticated access and can safely carry clinical detail, and text messages, which require consent since they travel unencrypted. The same minimum necessary rule applies everywhere, but voicemail is where it matters most. Keep it generic and let the callback handle the rest. Question 25. Which bone of the body articulates with the pelvis at the hip joint? Your options are femur, B. tibia, C. fibula, D. humerus. Which one is it? Pause the video if you need more time. The correct answer is A. Femur. A is correct because the femur is the long bone of the thigh that articulates with the pelvis at the hip joint. Hip fractures in older adults most often involve the femoral neck or intertrochanteric region of the femur. B is wrong because tibia is the larger weight-bearing bone of the lower leg between the knee and ankle, so it does not articulate with the pelvis at the hip joint described in this anatomy question. C is wrong because fibula is the slender lateral bone of the lower leg that does not articulate with the pelvis, so it is not involved in the hip joint where the thigh meets the pelvis. D is wrong because humerus is the long bone of the upper arm running from shoulder to elbow, so it is not part of the lower extremity hip joint described in this anatomy question. The hip is one of only two ball and socket joints in the body, the other being the shoulder, and it exists to solve a problem. How do you bear weight and still move freely? The femoral head sits deep inside the acetabulum, cushioned by articular cartilage and lubricated by synovial fluid, while the labrum and powerful ligaments hold the two surfaces tightly together. Notice how the femoral neck angles upward and medially into the shaft, a geometry that gives the gluteal muscles leverage but also concentrates stress, making this the classic fracture site in older adults with osteoporosis. Exam traps hinge on matching the joint to the correct bone. The femur articulates with the pelvis at the hip and with the tibia and patella at the knee. The tibia and fibula meet the femur and talus, but never the pelvis. And the humerus meets the scapula at the shoulder. Contrast the three. The knee is a hinge between femur and tibia. The shoulder is a shallow ball and socket relying on the rotator cuff for stability. And the hip is the deep, stable, weight-bearing ball and socket joint built for standing, walking, and climbing. So whenever a stem describes a fall, a shortened externally rotated leg, and hip pain in an older adult, the bone in question is the femur, because it's the only long bone that articulates with the pelvis at the hip. Question 26. A medical assistant is preparing to install eardrops in a 6-year-old child. Which of the following techniques is most appropriate? Your options are A. Pull the pinner down and back, B. Pull the pinner straight up only, C. Pull the pinner up and back, D. Press behind the ear without moving the pinner. Take a second. Which answer would you pick? The correct answer is C. Pull the pinner up and back. C is correct because for children 3 years and older and for adults, the pinner is pulled up and back to straighten the ear canal during drop installation. For children younger than 3 years, the pinner is pulled down and back instead. A is wrong because pulling down and back is the correct technique for children younger than 3 years old, not for a school-age child of 6 who has the more adult-like ear canal anatomy already developed clinically. B is wrong because pulling straight up does not align the canal effectively in any age group, and is not the recommended technique in either pediatric or adult eardrop installation in clinical practice settings today either. D is wrong because pressing behind the ear without moving the pinner does not straighten the canal and would prevent drops from reaching the right area during installation in children of any age routinely seen during care. Aortic drops only work if they reach the eardrum, and the trick to getting them there depends on a small anatomic detail that changes with age. In young children, the canal angles upward and forward, so pulling the pinner down and back straightens the path. Once the canal matures around age 3, it takes on a more adult, horizontal shape, and pulling the pinner up and back does the job instead. Signal words point straight to the technique. Infant, toddler, and younger than 3 mean down and back. School-aged child, adolescent, adult, and matured canal mean up and back. A few details apply no matter the age. Warming the drops prevents dizziness from cold fluid hitting the inner ear. Lying on the unaffected side and staying still lets gravity carry the medication in. And keeping the dropper from touching the skin prevents contaminating the bottle. Every aortic root has its own trick. And for the ear, that trick is choosing the right pinner pull for the patient's age so the medication can finally do its job. Question 27. A patient asks the medical assistant for a personal opinion on a treatment option being considered. Which of the following is the most appropriate response? Your options are A. Share what worked for a relative. B. Refer the question to the provider. C. Recommend the cheapest option available. D. Tell the patient to research online. Before I reveal it, which one do you think is right? The correct answer is B. Refer the question to the provider. B is correct because medical assistants must stay within scope and not counsel on treatment options, so the appropriate response is to validate the question and refer it to the provider, who can discuss risks and benefits. A is wrong because sharing what worked for a relative substitutes anecdote for clinical guidance, exceeds the medical assistant's scope of practice, and may steer the patient away from the provider's evidence-based recommendation in this situation. C is wrong because recommending the cheapest option exceeds the medical assistant's scope, ignores clinical considerations, and may lead the patient toward a treatment that is not appropriate without provider input or counseling first. D is wrong because telling the patient to research online abandons the patient's question, fails to validate the concern, and may direct the patient to unreliable sources rather than the provider's professional clinical guidance and counsel. Scope of practice is the legal fence around what a medical assistant may do under state law and provider delegation. Stepping outside that fence puts the patient, the practice, and the assistant at risk. Diagnosing, prescribing, and recommending therapy all sit within the licensed scope of physicians, nurse practitioners, and physician assistants. The medical assistant supports those decisions but never makes a substantive clinical call. When a patient asks for an opinion, the assistant validates the concern, declines to give a personal recommendation, and routes the question back to the provider who can discuss risks, benefits, and alternatives. Reinforcing teaching means restating what the provider already explained in plain language. Counseling on treatment means weighing options and steering a patient toward one, which is prescribing adjacent and outside scope. Whether it's administering a vaccine, drawing blood, or reinforcing instructions, delegated tasks never cross into recommending therapy. That line is what keeps a medical assistant safely within scope. Question 28. A medical assistant is preparing a referral packet for a specialist after the provider signs the order. Which of the following components should be included in a complete referral? Your options are A. Patient demographics only. B. Provider signature only. C. Diagnosis code only. D. Reason, records, diagnosis, and urgency. What's your answer? Commit to one before I continue. The correct answer is D. Reason, records, diagnosis, and urgency. D is correct because a complete referral includes patient demographics, referring provider information, reason for the referral, diagnosis code, urgency level, pertinent records, insurance authorization, and patient consent. Completeness reduces delays and supports specialist preparation for the consult visit. A is wrong because demographics alone leave the specialist without clinical context. A referral without a reason or supporting records leads to delays, repeat testing, and patient frustration on arrival at the consult, and slows the closed-loop referral process between practices. B is wrong because the provider signature is required but is only one component of the referral packet. Without supporting clinical content such as the reason, urgency, and pertinent records, the signed referral is incomplete and slows specialist evaluation at the consult. C is wrong because the diagnosis code alone is insufficient for the specialist to prepare. The specialist needs the clinical question, urgency, and supporting records to plan the consult appropriately and to avoid duplication of testing already completed by the referring practice. A referral is more than an order signed by a provider. It's a loop that opens when the need is identified and closes only when the consult note comes back and gets reviewed. A complete packet is a checklist, not a single form. It includes patient demographics, referring provider information, the reason for referral written as a clinical question, diagnosis codes, urgency level, pertinent records, and insurance or prior authorization details. Picture the packet flowing out from primary care to the specialist with the clinical question and supporting records, and the consult note flowing back with recommendations. The loop only closes when both halves connect. On exams, a single piece like a demographics page or a signed order is necessary but never sufficient on its own. The correct answer is always the bundle that brings reason, records, diagnosis, and urgency together. A medical assistant who assembles a complete packet and tracks the returning consult note keeps the entire referral system working for every patient on the panel. Question 29. Before performing a CLIA-waived rapid strep test, a medical assistant reviews the quality control schedule. Which of the following is most appropriate for routine quality control? Your options are A. Follow manufacturer schedule and lot changes. B. Run only after equipment failure. C. Run only on the first day yearly. D. Treat as optional for wave tests. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is A. Follow manufacturer schedule and lot changes. A is correct because wave testing requires following manufacturer instructions exactly, including running quality control with each new lot or shipment, after maintenance, and at specified intervals. The quality control log documents runs and corrective actions when results fail. B is wrong because limiting quality control to post-failure events misses lot change drift and routine performance checks that prevent inaccurate patient results, which is the core purpose of CLIA waived requirements in office testing. C is wrong because an annual quality control schedule cannot detect lot-to-lot variation or daily reagent issues, which the manufacturer typically addresses with much more frequent runs across each shipment of test kits used clinically. D is wrong because even wave tests require quality control per manufacturer instructions to maintain the certificate of waiver and to ensure trustworthy patient results that providers will rely on for treatment decisions consistently over time. CLIA regulates lab testing on human specimens, sorting tests by complexity. Wave tests, like rapid strep or fingerstick glucose, are simple enough that errors are minimized when instructions are followed exactly. Quality control exists because even simple tests can fail. Reagents degrade, refrigerator temperatures drift, new lots vary, and operator technique loosens over time. Running a known control before testing patients catches these problems before they cause harm. The QC log is the evidence trail. Every entry records the date, lot number, operator, control result, and any corrective action, proving the test system was verified before it touched a single patient sample. The manufacturer's instructions define exactly when controls must run, with a new cartridge lot, after maintenance, when an operator is new, when results look inconsistent, or at set intervals like monthly. Waiting only for a visible failure misses gradual drift that routine QC would catch early. Waived means simple, not exempt. Skipping routine quality control. Favoring only post-failure checks or annual testing risks missed errors, regulatory citations, and patient harm, while a disciplined QC log earns the certificate of waiver every single day. Question 30. Which pancreatic cells are destroyed in type 1 diabetes mellitus, eliminating insulin production? Your options are A. Alpha cells, B. Delta cells, C. Beta cells, D. acinar cells. Which would you go with? Lock it in before the reveal. The correct answer is C. Beta cells? C is correct because beta cells in the pancreatic islets produce insulin, which signals body cells to take up glucose. In type 1 diabetes, autoimmune destruction of beta cells eliminates insulin production, requiring lifelong replacement injections for survival. A is wrong because alpha cells in the pancreas produce glucagon that raises blood glucose by signaling the liver to release stored sugar, so their loss would not produce the insulin deficiency seen in type 1 diabetes. B is wrong because delta cells in the pancreas produce somatostatin that helps regulate other islet hormones, so their destruction does not produce the insulin deficiency that defines type 1 diabetes mellitus in patients today. D is wrong because acinar cells of the pancreas produce digestive enzymes such as amylase and lipase, so they are exocrine cells unrelated to the insulin-producing islet cells destroyed in type 1 diabetes mellitus. The pancreas is both an exocrine and endocrine organ, and inside its islets of Langerhans lies the cell responsible for the entire story of diabetes, the beta cell. Within each islet, 4 distinct cell types each secrete a different hormone. Alpha cells make glucagon, beta cells make insulin, delta cells make somatostatin, and PP cells make pancreatic polypeptide. Insulin acts like a key. After a meal, rising glucose triggers beta cells to release it, unlocking muscle, fat, and liver cells so they can absorb glucose and store it as glycogen, keeping blood sugar in a tight, stable range. Type 1 diabetes is autoimmune destruction of beta cells, usually striking in childhood and requiring insulin from day 1. Type 2 diabetes is insulin resistance with relative beta cell insufficiency, typically appearing in adulthood and often manageable with lifestyle changes before insulin is needed. Whenever a question points to autoimmune destruction, ketoacidosis, or lifelong insulin dependence, the answer traces back to the beta cell of the pancreatic islet. Question 31. A patient asks why he takes atorvastatin daily. The medical assistant should explain that this medication primarily targets which of the following conditions. Your options are A. Atrial fibrillation, B. Hyperlipidemia, C. Heart failure, D. Asthma. Don't overthink it. Which one feels right? The correct answer is B. Hyperlipidemia. B is correct because atorvastatin is an HMG-CoA reductase inhibitor used to lower cholesterol in hyperlipidemia. Lowering LDL cholesterol reduces the risk of cardiovascular events such as heart attacks and strokes through its effect on liver enzymes. A is wrong because atrial fibrillation is a rhythm disorder treated with anticoagulants, rate control agents, and antiarrhythmics rather than with cholesterol-lowering statins. So atorvastatin is not the primary therapy used to reduce stroke risk in this rhythm. C is wrong because heart failure is managed primarily with ACE inhibitors, beta blockers, diuretics, and aldosterone antagonists rather than with a statin. So atorvastatin is not the agent used to address fluid overload symptoms in this condition. D is wrong because asthma is an airway disorder treated with bronchodilators and inhaled corticosteroids rather than with a cholesterol-lowering medication. So atorvastatin has no meaningful role in long-term asthma control in adult patients today. Maslow's hierarchy of needs is a 5-tier pyramid model of human motivation, ranking our requirements from basic survival at the bottom to higher psychological growth at the top. The base level covers physiological needs like food, water, oxygen, sleep, warmth, and elimination. Above that comes safety, then love and belonging, then esteem, with self-actualization at the very top. The mechanism is simple. Each tier depends on the ones below it. A patient who is struggling to breathe or hasn't eaten in days cannot meaningfully focus on belonging or self-improvement because survival circuitry overrides higher level thinking. This is why clinicians triage survival first: air, water, food, sleep, and elimination anchor the foundation. And any of these can be a clue word pointing to that bottom tier on an exam. So when rooming a patient, always scan for unmet basic needs like hunger, breathing, or warmth before exploring emotional concerns like loneliness or purpose. Question 32. A medical assistant is preparing to draw blood from a patient. Which vein in the antecubital fossa is the preferred first choice? Your options are A. Median cubital vein, B. Basilic vein, C. Cephalic vein, D. Axillary vein. Got a guess? Lock it in. The correct answer is A. Median cubital vein. A is correct because the median cubital is the first choice because it is well anchored, less painful, and farther from major nerves and the brachial artery than the basilic. The cephalic is a reasonable second option if median cubital is unavailable. B is wrong because the basilic vein is the last choice because it lies near the brachial artery and median nerve, increasing the risk of injury and pain during routine antecubital venipuncture procedures performed in clinic today. C is wrong because the cephalic vein is acceptable as a second choice, but tends to roll more than the median cubital and is harder to anchor during venipuncture, especially in older adults with thinner skin overlying it. D is wrong because the axillary vein is in the upper chest and arm region and is not a venipuncture site for routine blood collection in any adult or pediatric standard practice setting in clinics across the country. The testes run 2 separate operations at once, making sperm and making testosterone. Knowing exactly which cell handles which job is the key to avoiding the most common trap on hormone and fertility questions. Leydig cells sit in the interstitial space between the seminiferous tubules, converting cholesterol into testosterone, right next door, but doing a completely different job. Sertoli cells line the inside of the tubules, nursing developing sperm and releasing inhibin. 4 structures get mixed up constantly. Leydig cells make the hormone. Sertoli cells support sperm development without producing testosterone. Spermatogonia are the germ cells that mature into sperm, and Cowper glands sit entirely outside the testes, making pre-ejaculate fluid for urethral lubrication. Picture the interstitial space as a hormone factory and the tubule lining as a nursery next door. The factory ships testosterone throughout the body, while the nursery quietly raises spermatogonia into mature sperm. When a stem asks about the source of testosterone, hypogonadism, or replacement therapy, picture the interstitial Leydig cell as the factory driving the answer. Question 33. A medical assistant is collecting a coagulation light blue tube using a butterfly set when it is the first or only tube ordered. Which of the following is the reason a discard tube is needed? Your options are: A. It wets the additive before sample collection. B. It fills dead space in the butterfly tubing. C. It removes needle bevel contamination. D. It verifies safety device engagement. Which one is it? Pause the video if you need more time. The correct answer is B. It fills dead space in the butterfly tubing. B is correct because butterfly tubing holds approximately 0.5 milliliter of dead space. A discard tube fills that gap, so the citrate tube draws to the proper line and maintains the 9:1 blood to additive ratio required for accurate coagulation testing afterward. A is wrong because the additive in a citrate tube is liquid and ready, so it does not need to be wetted before sample collection is started during a routine butterfly draw on a coagulation panel ordered today in clinic. C is wrong because the needle bevel is not contaminated by routine collection in a way that requires a discard tube. Standard antiseptic technique addresses skin contamination during preparation of the venipuncture site itself instead. D is wrong because the safety device is checked at the end of collection during withdrawal, not by drawing a discard tube during the actual collection process at the start of a venipuncture today in clinic. After centrifugation, a blood specimen can show visual clues that something is wrong with the sample. Recognizing these patterns helps prevent unreliable lab results from reaching the provider. 3 classic interferons each produce a distinct color. A milky, turbid layer signals lipemia, a pink or red tint signals hemolysis, and a deep yellow or amber color signals icterus. ETA contamination is the trap, since it corrupts chemistry results without ever changing the sample's appearance. The reason this matters is optical. Chemistry analyzers read light absorbance through the sample. Lipid particles scatter light. Free hemoglobin absorbs at overlapping wavelengths, and bilirubin absorbs in the yellow range. So each substance throws off the reading in its own way. Memorize the signal words for each pattern. Lipemia looks milky and links to a recent fatty meal. Hemolysis looks pink to red from ruptured cells. And icterus looks deep yellow from elevated bilirubin. ETA contamination is the outlier, corrupting potassium, calcium, and magnesium with no visible color clue at all. When serum looks turbid and milky after spinning, think lipemia from a recent meal or high triglycerides, and recollect in the fasting state when feasible. This gives the provider a clean, trustworthy result for managing the patient's care. Question 34. A patient reports taking a friend's leftover ibuprofen and a daily multivitamin she stopped 2 months ago. Which of the following is the most appropriate documentation by the medical assistant? Your options are: A. List the multivitamin as currently active. B. Omit ibuprofen because it is over the counter. C. Document both medications including borrowed ibuprofen. D. Record only filled prescriptions in the chart. Take a second. Which answer would you pick? The correct answer is C. Document both medications including borrowed ibuprofen. C is correct because medication reconciliation captures prescriptions, over-the-counter products, supplements, and borrowed medications. Documenting borrowed ibuprofen alerts the provider to bleeding risk while updating the discontinued multivitamin keeps the active medication list accurate. A is wrong because listing a discontinued vitamin as currently active misleads the provider, contaminates reconciliation, and risks duplicate or interacting orders going forward at this visit and at every future encounter in the chart. B is wrong because over-the-counter analgesics interact with anticoagulants and many prescription medications and meaningfully change bleeding risk, so they belong on every reconciled medication list regardless of whether they are prescribed. D is wrong because limiting the list to filled prescriptions ignores supplements, over-the-counter products, and shared medications that materially affect drug interactions and clinical decisions during care planning at the visit today. Step therapy is a utilization management strategy insurers use to control drug costs while still allowing access to expensive specialty medications when they're truly needed. The key nuance for the exam is that step therapy doesn't bypass prior authorization. It's a specific gateway within it. Documentation of a failed or intolerable trial is what unlocks approval, not a way around the process. Here's how it plays out in practice. A provider prescribes a costly drug. The insurer rejects it citing step therapy. The clinical team compiles proof of prior trials, submits it for prior authorization, and only then does approval follow. Watch for signal words like trial of cheaper option first, fail and switch, and documented an adequate response. These point to step therapy. Phrases like immediate brand approval or no documentation needed are red flags pointing away from it. Ultimately, step therapy requires documented proof that cheaper options failed before a costlier drug is approved. The medical assistant gathers those records, completes the paperwork accurately, and keeps the patient informed during the wait. Question 35. Which type of feedback mechanism dominates physiological homeostasis by reversing changes from a set point? Your options are A. Positive feedback loop, B. Negative feedback loop, C. Open loop response, D. Random fluctuation control. Before I reveal it, which one do you think is right? The correct answer is B. Negative feedback loop. B is correct because negative feedback dominates physiological homeostasis. When a variable strays from its set point, sensors signal effectors to reverse the change. Examples include insulin reducing high blood glucose and baroreceptors adjusting heart rate effectively. A is wrong because positive feedback amplifies a stimulus rather than reversing it, used an oxytocin release during labor and the clotting cascade, so it is not the dominant homeostasis mechanism for stable temperature, glucose, and pressure. C is wrong because open loop response systems do not adjust based on output feedback and therefore cannot maintain a precise set point, so they are not the dominant homeostatic mechanism in temperature, glucose, and pressure control. D is wrong because random fluctuation is not a regulated control mechanism in physiology, since the body actively maintains variables through coordinated sensor and effector pathways, rather than allowing random, unregulated changes around target values. Home health care brings skilled medical services directly into a patient's home instead of a clinic, hospital, or facility. It exists so patients recovering from surgery or illness can heal in a familiar environment while still receiving the care they need. To qualify, a patient must be homebound, meaning leaving home takes considerable and taxing effort. Care is delivered under physician orders with a documented plan of care through intermittent skilled visits rather than daily ongoing supervision. The process starts with a face-to-face visit where the clinician certifies homebound status and signs the plan of care. The agency then assigns a registered nurse for an admission assessment, coordinates therapy disciplines, and continues visits until goals are met. On the exam, distinguish home health from similar options. Skilled nursing facility care means facility admission after a qualifying hospital stay. Hospice focuses on comfort for a 6-month prognosis, and inpatient rehab requires 3 or more hours of daily therapy as an inpatient. Home health delivers skilled, intermittent services to homebound patients right in their own homes, supporting recovery and reducing readmissions. The medical assistant supports this by gathering documentation and ensuring certifications are signed on time. Question 36. A patient from a collectivist culture requests that her adult children participate in treatment decisions. Which of the following is the most appropriate response by the medical assistant? Your options are A. Respect the family's role in decisions. B. Ask the family to leave the room. C. Tell the patient to decide alone. D. Refuse to proceed with the visit. What's your answer? Commit to one before I continue. The correct answer is A. Respect the family's role in decisions. A is correct because cultural humility requires the medical assistant to honor family decision-making practices common in collectivist cultures, while still confirming the patient consents to and understands the proposed plan of care. B is wrong because asking the family to leave dismisses the patient's cultural framework, undermines trust, and conflicts with cultural humility expectations central to respectful, patient-centered care delivery in this clinical scenario today. So is wrong because telling the patient to decide alone violates cultural humility, ignores collectivist family roles, and may cause the patient to disengage or refuse care altogether during this office encounter today. D is wrong because refusing to proceed punishes the patient for cultural practices, violates ACA Section 1557 non-discrimination protections, and reflects neither patient-centered care nor reasonable accommodation of cultural preferences shown. A closed-loop referral means the referring practice tracks a patient all the way from the order to the specialist visit, and finally to the consult report landing back in the chart. The loop only closes when the consult note actually returns and the provider reviews it during a later encounter. Without that final step, findings and treatment plans can quietly fall through the cracks. The mechanism involves several handoffs. The provider orders the referral. The medical assistant assembles the packet. The specialist sees the patient, and a consult note travels back to the referring practice before the provider closes the loop. If a patient confirms attending cardiology but no note has arrived, cancelling the order or discharging the patient solves nothing. The correct action is calling the specialist office to request the missing consult report. The medical assistant plays a central role, tracking pending referrals, following up on missing reports, and documenting every step in the referral log until the loop truly closes. Question 37. Which public health term describes separating individuals who have been exposed to a contagious disease but are not yet symptomatic? Your options are A. Isolation, B. Mitigation, C. Surveillance, D. Quarantine. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is D. Quarantine. D is correct because quarantine separates people who have been exposed to a contagious disease but are not yet symptomatic, while isolation separates people already known to be sick. Both strategies limit further spread during outbreaks and pandemics. A is wrong because isolation separates people already known to be sick from others to prevent further transmission. So it does not describe the separation of exposed but well individuals during an outbreak as described. B is wrong because mitigation describes broad public health strategies such as social distancing, masking, and closures during an outbreak, so it does not specifically describe separating exposed but well individuals from the population. C is wrong because surveillance describes ongoing monitoring of disease patterns through wastewater, lab reporting, and syndromic data collection. So it does not describe separating exposed but well individuals during an outbreak response. Inclusive intake practices mean capturing both a patient's legal name and chosen name, along with pronouns, and placing each in the right part of the record. Legal name stays in registration and billing fields since insurance verification depends on that exact match. Chosen name, pronouns, and gender identity appear on banner bars, schedules, and rooming screens that staff see during direct interaction. On the banner bar, the chosen name and pronouns display prominently for clinical staff, while legal name quietly remains in the billing and lab fields, so claims and specimens still match insurer and lab records. Test distractors often involve demanding a legal name change, ignoring stated pronouns, or disclosing gender history to co-workers without consent. Each of these fails to honor the patient and can breach privacy or non-discrimination protections. Documenting chosen name and pronouns while keeping legal name where billing requires it is the standard of inclusive ambulatory care. The medical assistant's job is to capture it at intake, enter it correctly, use it consistently, and share only what's necessary on a need-to-know basis. Question 38. After leaving the right ventricle, blood passes through which valve before entering the pulmonary artery? Your options are aortic valve, B. pulmonary valve, C. mitral valve, D. tricuspid valve. Which would you go with? Lock it in before the reveal. The correct answer is B. pulmonary valve. B is correct because the pulmonary valve is a semilunar valve located between the right ventricle and the pulmonary artery. It opens during right ventricular systole, allowing deoxygenated blood to travel toward the lungs for gas exchange. A is wrong because aortic valve sits between the left ventricle and the aorta on the systemic side of the heart, so it does not handle blood leaving the right ventricle on the way to the pulmonary artery. C is wrong because mitral valve sits between the left atrium and left ventricle on the oxygenated side of the heart, so it does not control flow leaving the right ventricle on the way to the lungs. D is wrong because tricuspid valve sits between the right atrium and right ventricle, so it controls flow into the right ventricle rather than out of the right ventricle toward the pulmonary artery and lungs. Therapeutic communication is the toolkit clinical staff use to support patients emotionally while gathering key clinical information. Reflection, active listening, open-ended questions, silence, clarification, and summarization all share one purpose: validate feelings and invite the patient to keep talking. The mechanism is simple: name the feeling and invite more conversation. When a patient says the situation feels hopeless, the medical assistant mirrors that emotion back without judgment, which validates the patient and opens space for the next sentence. On exam items, distractors include false reassurance like promising things will improve, why questions that probe motivation, and abrupt departures that leave the patient alone. Each blocks communication while reflection alone names the feeling and stays present. Picture a patient with a recent cancer diagnosis saying the situation feels hopeless. The medical assistant pauses, reflects that hopelessness back gently, and the patient opens up about the fear and exhaustion underneath, while the assistant documents and alerts the provider without ever leaving the room. Mirroring a patient's feeling without judgment builds trust and invites disclosure, a skill every clinical team member needs from rooming through follow-up care. Question 39. A medical assistant is preparing the room for a routine 12-lead electrocardiogram on an adult patient. Which of the following positioning approaches is most appropriate? Your options are A. Supine, comfortable, warm, with limbs supported. B. Seated upright with legs crossed. C. Standing with arms at the sides. D. Prone with arms overhead. Don't overthink it. Which one feels right? The correct answer is A. Supine, comfortable, warm, with limbs supported. A is correct because supine positioning with the patient warm, comfortable, with limbs supported, and silent reduces somatic tremor, wandering baseline, and movement artifacts. Cell phones, electric beds, and fluorescent lights are moved away to limit electrical interference on the recorded tracing. B is wrong because crossed legs and seated position increase muscle tension and may produce baseline shifts and tremor artifact during recording attempts, especially when the patient is anxious or uncomfortable in the chair already at the visit. C is wrong because standing introduces postural shifts and continuous muscle activity that produce somatic tremor and baseline wander on the recorded tracing immediately, defeating the purpose of a calm resting EKG study performed in clinic today. D is wrong because prone positioning with arms overhead is inappropriate and prevents standard chest lead placement on the anterior chest wall, where precordial electrodes need to make contact during the procedure routinely performed in clinic. Precordial lead placement is the standard system of 6 chest electrode positions, V1 through V6, used to capture the anterior and lateral views of the heart during a 12-lead ECG. Getting these landmarks exactly right matters, because misplaced leads can mimic or hide real findings like ischemia and infarction. The heart's electrical activity moves in 3-dimensional vectors through the chest, so capturing it fully means sampling from multiple angles. The 6 precordial leads view the heart from the right ventricle, across the septum, over the apex, and out to the lateral wall of the left ventricle. Placement starts at the angle of Lua, the ridge where the sternum's manubrium meets its body, near the second rib. Counting down to the 4th intercostal space locates V1 at the right sternal border and V2 at the left sternal border, with V3 splitting the distance to V4 at the 5th intercostal space, mid-clavicular line, and V5 and V6 extending laterally at that same horizontal level. Each lead has its own signal words worth memorizing. V1 is 4th intercostal space, right sternal border. V2 shares that intercostal space but sits on the left. V4 anchors the 5th intercostal space at the midclavicular line, while V5 and V6 share that same horizontal level at the anterior and mid-axillary lines. Remember, V1 belongs at the 4th intercostal space at the right sternal border, giving the right-sided anterior view of the heart. Accurate placement of all 6 leads forms the foundation for a reliable tracing the provider can trust. Question 40. A patient develops a widespread blistering rash with mucosal involvement and fever 2 days after starting an antibiotic. Which of the following best describes this reaction? Your options are A. Side effects, B. Adverse drug reaction, C. Idiosyncratic reaction, D. Drug-food interaction. Got a guess? Lock it in. The correct answer is B. Adverse drug reaction. B is correct because adverse drug reactions are unintended, harmful, sometimes severe responses that may require dose change or discontinuation. Stevens-Johnson syndrome and similar severe skin reactions to antibiotics are classic adverse reactions requiring urgent action and surveillance reporting. A is wrong because a side effect describes mild predictable secondary effects at therapeutic doses such as nausea or dry mouth, not a severe blistering rash with mucosal involvement and systemic symptoms that requires emergency department evaluation and immediate drug discontinuation. C is wrong because an idiosyncratic reaction describes unusual individualized reactions that cannot be predicted from the drug's known properties, which can overlap with severe reactions but does not capture the broader category of harmful unintended responses to a medication. D is wrong because a drug-food interaction requires food interacting with medication, such as warfarin and leafy greens or MAO inhibitors and aged cheese, which does not match the picture of severe rash and systemic symptoms after a new antibiotic. Vitamin B12 or cobalamin is essential for red blood cell production, nerve health, and DNA synthesis. It's found almost exclusively in animal source foods, and because the liver stores years' worth, deficiency develops slowly and quietly. B12 acts as a cofactor in two places no other nutrient can replace: bone marrow, where red cells mature, and nerve fibers, where it maintains the myelin sheath. Without it, red cells grow oversized, causing macrocytic anemia, while nerves gradually lose their coating, causing tingling, numbness, and weakness. The diagnostic shortcut for the exam is recognizing this exact combination: a strict vegan patient with macrocytic anemia and neurologic symptoms like tingling and fatigue. That pairing points specifically to cobalamin, not to other vitamins. Each distractor vitamin has its own fingerprint. Vitamin C causes scurvy and bruising. Vitamin D causes bone pain and rickets. And vitamin A causes night blindness. Only B12 produces the unique combination of macrocytic anemia and neuropathy. Strict vegans without supplementation are at real risk for B12 deficiency. Watch for the combination of large red cells and nerve symptoms. And remember the medical assistant's role in screening diet, flagging symptoms, and reinforcing education on fortified foods. Question 41. Which artery most commonly becomes obstructed during a myocardial infarction in adult patients? Your options are A. Coronary artery, B. Subclavian artery, C. Pulmonary artery, D. Renal artery. Which one is it? Pause the video if you need more time. The correct answer is A. Coronary artery. A is correct because coronary arteries supply oxygenated blood to the heart muscle itself. Atherosclerotic narrowing or rupture in a coronary artery is the most common cause of myocardial infarction with chest pain in adult patients. B is wrong because subclavian artery supplies the upper extremity through the axillary and brachial branches. So its narrowing causes arm symptoms rather than the heart muscle damage and chest pain pattern of myocardial infarction. C is wrong because pulmonary artery carries deoxygenated blood from the right ventricle to the lungs. So blockage causes pulmonary embolism rather than the heart muscle damage pattern described in this myocardial infarction question. D is wrong because renal artery supplies the kidney with blood, so its narrowing causes hypertension and kidney injury rather than the heart muscle damage and acute chest pain pattern described in myocardial infarction. The heart pumps blood through its chambers constantly, but that blood never actually feeds the heart muscle itself. The muscle gets its own dedicated supply from the coronary arteries. The right and left coronary arteries branch off the aorta and wrap around the heart's surface. The left coronary splits into the left anterior, descending and circumflex branches, while the right coronary feeds the inferior wall and, in most people, the SA and AV nodes. Coronary obstruction builds in 3 layers. First, smoking, hypertension, or diabetes injure the artery lining. Then cholesterol-laden plaque grows beneath that injury. And finally, when the fibrous cap tears, clotting factors rush in and form a thrombus that blocks flow. Exam STEMs love distractors. Subclavian artery problems cause arm coolness, not chest pain. Pulmonary artery clots cause pulmonary embolism. Renal artery narrowing causes resistant hypertension. Always anchor crushing chest pain, radiation to the jaw, and diaphoresis back to the coronary territory. When a STEM describes chest pressure with cardiac risk factors, the coronary artery is the vessel in trouble, and every minute without flow costs heart muscle. Question 40. A medical assistant finds the vaccine refrigerator temperature out of range during the morning check. Which of the following actions should the medical assistant take? Your options are A. Erase the abnormal entry. B. Skip recording until normal again. C. Wait 1 week to recheck. D. Document the corrective action taken. Take a second. Which answer would you pick? The correct answer is D. Document the corrective action taken. D is correct because equipment logs require recording the date, time, value, and corrective action when the reading is out of range. The medical assistant must document the abnormal reading and notify staff per protocol per CDC vaccine storage guidance. A is wrong because erasing entries violates documentation rules in clinical records. Logs are official records, and tampering could result in regulatory violations and loss of vaccine accountability for the practice during state immunization program audits or inspections of cold chain documentation. B is wrong because skipping documentation until the temperature normalizes hides the problem and the timeline of the excursion. Continuous, accurate temperature logs are required by CDC and manufacturer storage guidelines for vaccines stored in refrigerators within the practice setting. C is wrong because waiting a week to recheck risks vaccine waste and patient safety. Out-of-range temperatures require immediate evaluation, corrective action, and quarantine of affected vaccines rather than delayed reassessment of compromised storage conditions during routine clinic operations. Vaccines are biologic products with narrow temperature tolerances, so daily refrigerator monitoring protects what's called the cold chain. When a reading falls outside range, that's an excursion, and the unit becomes suspect until evaluated. Documentation matters because a temperature excursion can degrade a vaccine without any visible sign. A patient who receives a compromised dose may believe they're protected when they aren't, and vaccines for children programs require strict cold chain records, putting eligibility, dossiers, and patient safety all at stake. The mechanism is straightforward. The abnormal reading is recorded exactly as observed. Affected vaccines are quarantined with do not use tags, and the supervisor and immunization program are notified for a stability determination. The corrective action and outcome are then documented alongside the original entry. Erasing or whiting out an abnormal entry counts as falsifying a clinical record. Skipping documentation hides the timeline, and waiting to recheck a flagged unit is unacceptable since more doses could be given in the meantime. Whether it's a fridge above 8 degrees or a freezer past its threshold, the correct choice is always to document, quarantine, and notify, never to erase, skip, or wait. Question 43. A medical assistant prepares a subcutaneous injection. Which of the following sites is most appropriate for this route? Your options are A. Anterior thigh outer aspect, B. Deltoid muscle midpoint, C. Ventrogluteal muscle area, D. Dorsal forearm dermis only. Before I reveal it, which one do you think is right? The correct answer is A. Anterior thigh outer aspect. A is correct because subcutaneous injections target fatty tissue beneath the skin at sites such as the outer upper arm, abdomen, or anterior thigh. Deltoid and ventrogluteal sites are intramuscular, while the dorsal forearm is used for intradermal skin testing. B is wrong because the deltoid muscle midpoint targets muscle for intramuscular injections such as flu vaccine, and would deliver the dose deeper than subcutaneous requires, changing absorption and making it inappropriate for SC medications such as insulin or heparin. C is wrong because the ventrogluteal muscle area targets a deep gluteal muscle for IM, injections such as ceftriaxone or certain antipsychotics and is not appropriate for subcutaneous medications, which require placement in the fatty layer above muscle tissue. D is wrong because the dorsal forearm dermis targets the dermis for skin testing such as TB or allergy assessments and is too shallow for subcutaneous medications, so it would not provide the tissue depth required for typical SC drug administration. Subcutaneous injections deposit medication into the fatty layer between skin and muscle, giving absorption that's slower than intramuscular but faster than oral. This makes it ideal for insulin, heparin, biologics, and many vaccines. Because fat is poorly vascularized compared to muscle, medication seeps out gradually instead of rushing into circulation. That's exactly why insulin can mimic the body's natural basal and bolus release, and why heparin achieves steady, sustained anticoagulation. Site selection depends on tissue depth. The outer thigh and abdomen offer generous fat pads and are easy for self-injection. The upper outer buttock works too, and the outer upper arm suits vaccines and small volumes. Rotating sites prevents lipohypertrophy, a thickened bump that disrupts absorption. The exam loves testing this depth distinction. Subcutaneous needles are short and angled 45 to 90 degrees into the fat layer. Intramuscular sites like the deltoid or ventrogluteal use longer needles straight in at 90 degrees. And intradermal testing, like tuberculin skin test, uses a tiny needle at 10 to 15 degrees into the dermis. When a stem mentions insulin, heparin, or a biologic needing gradual absorption, think subcutaneous and choose a site based on fat depth, not muscle bulk or dermal access. Question 44. A patient signs the HIPAA Notice of Privacy Practices Acknowledgement, Consent for Treatment, and Assignment of Benefits at Registration. In which of the following sections of the medical record do these forms belong? Your options are A. Clinical progress notes, B. Lab and imaging results, C. Administrative section, D. Telephone encounter messages. What's your answer? Commit to one before I continue. The correct answer is C. Administrative section. C is correct because the administrative section of the chart holds demographics, insurance information, HIPAA acknowledgement, consent for treatment, financial responsibility forms, and advance directives. Clinical, billing, and free text sections hold different content with different retention rules. A is wrong because progress notes hold provider documentation of clinical encounters and assessment findings during the visit. They do not store demographic intake forms, insurance assignments, or privacy practice acknowledgement paperwork generated during the patient registration process at check-in. B is wrong because lab and imaging results hold diagnostic test reports for the patient. Privacy notices and consent forms are administrative documents that belong in their own dedicated section of the medical record and should not be filed with diagnostic results. D is wrong because telephone encounters document patient calls and clinical messages handled between visits. They do not house intake forms such as consent for treatment, HIPAA acknowledgements, or assignment of benefits paperwork generated during the patient registration workflow at check-in. Every medical chart has a legal and financial backbone, separate from the clinical story. That backbone is the administrative section, and knowing what belongs there is a recurring exam skill. This section holds demographics, insurance cards, the HIPAA Notice of Privacy Practices Acknowledgement, consent for treatment, and financial responsibility or assignment of benefits forms. These documents form the legal scaffolding around every clinical encounter, and they're kept separate because different staff use them for different purposes. Picture a new patient at the front desk signing a HIPAA acknowledgement, a consent for treatment, an assignment of benefits, and a financial responsibility form. All four travel together into the administrative section, while the clinical note from that same visit goes to the encounter or progress note section instead. Watch for signal words: HIPAA acknowledgement, consent for treatment, assignment of benefits, and release of information point to administrative filing, while progress note, lab report, and imaging study point elsewhere in the chart. Misfiling these documents isn't just messy, it can hide a HIPAA acknowledgement from an audit or delay a claim. When a STEM mentions form signed at registration, the answer is the administrative section. Question 45. A teen discloses thoughts of self-harm with a plan and access to means. Which of the following actions should the medical assistant take first? Your options are: A. Walk her to the parking lot. B. Schedule routine follow-up next week. C. Hand her a printed brochure. D. Stay with her and notify the provider. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is D. Stay with her and notify the provider. D is correct because when suicide risk is identified, the patient must never be left alone. The medical assistant should stay with her and notify the provider immediately so trained staff can assess and arrange safety planning or higher levels of care. A is wrong because walking her to the parking lot leaves the patient unsupervised in a vulnerable moment and ignores the requirement to keep high-risk patients safe, since this action removes the safety net the office can provide. B is wrong because scheduling routine follow-up next week delays needed intervention for a patient with active suicidal thoughts and a plan, which is dangerous and contrary to standard guidance, since high-risk patients require immediate evaluation rather than routine return appointments. C is wrong because handing her a printed brochure offers minimal support that fails to provide the immediate human and clinical attention required, since written materials cannot substitute for direct evaluation, safety planning, and connection to higher levels of care. When a patient discloses a plan and access to means, this is a clinical emergency, just like chest pain or anaphylaxis. What happens in the next 30 seconds determines everything that follows. The response follows a defined order. The clinical medical assistant stays physically present with a calm, non-judgmental tone. A second staff member is sent to alert the provider immediately, and means are gently moved out of reach whenever possible. A validated tool like the Columbia Protocol helps the provider assess risk, but that assessment can only happen because the patient was never left unsupervised. The clinical environment itself is the safety net. The exam distinguishes supportive presence from actions that quietly abandon the patient. Walking someone to the parking lot, scheduling a routine follow-up, or handing over a brochure all leave the patient alone or delay help. Staying with the patient and notifying the provider is the only correct response. When ideation combines with a plan and access to means, therapeutic listening alone is not enough. Stay with the patient, escalate to the provider without delay, and let trained staff take it from there. Question 46. A medical assistant is teaching a patient with type 2 diabetes how to plan a balanced meal. Which of the following best describes the plate method? Your options are: A. Skip carbohydrates entirely. B. Half vegetables, quarter protein, quarter starch. C. Eat only fruit and yogurt. D. Drink protein shakes only. Which would you go with? Lock it in before the reveal. The correct answer is B. Half vegetables, quarter protein, quarter starch. B is correct because the plate method recommends half the plate as non-starchy vegetables, a quarter as lean protein, and a quarter as starch carbohydrate, with water alongside. It supports portion control and consistent carbohydrate intake at every meal. A is wrong because skipping carbohydrates entirely is not realistic and not recommended for most patients with diabetes. Consistent, moderate carbohydrate intake matched to insulin or oral medication is the foundation of diabetes meal planning at home, rather than complete carbohydrate avoidance. C is wrong because fruit and yogurt are mostly carbohydrate, which raises blood sugar without protein and fiber balance. A whole meal pattern with vegetables and lean protein is recommended for stability of glucose control rather than a snack-only pattern of carbohydrate-heavy foods. D is wrong because protein shakes alone do not provide a balanced meal pattern overall. They miss the variety of fiber and micronutrients found in vegetables, whole grains, and fruits eaten as part of a structured plate-based approach to diabetes meal planning. The plate method is a visual meal planning tool that helps patients with diabetes build balanced meals without counting a single carbohydrate gram. Half the plate is filled with non-starchy vegetables, 1/4 holds lean protein, and the last quarter contains a carbohydrate-rich starch, rounded out with a piece of fruit and a glass of water. 3 mechanisms work together: fiber-rich vegetables slow gastric emptying and blunt glucose spikes. Lean protein boosts satiety and slows digestion further, and limiting starch to 1/4 caps the carbohydrate load per meal. Picture the plate itself, half covered in leafy greens and broccoli, 1/4 holding grilled fish or chicken, and the final quarter reserved for brown rice or sweet potato. Whenever a STEM mentions a newly diagnosed patient overwhelmed by carb counting, the visual, proportion-based plate method is the answer to picture. Question 47. A patient at a federally qualified health center asks how the sliding fee scale is applied to charges. Which of the following best describes the program? Your options are A. Tiered discount based on income. B. Same fee for everyone. C. Free care without any review. D. Discount only for the uninsured. Don't overthink it. Which one feels right? The correct answer is A. Tiered discount based on income. A is correct because federally qualified health center sliding fee scales offer tiered discounts on charges based on household income relative to the federal poverty level. Patients reapply annually with documentation, and discounted charges keep care accessible to vulnerable populations. B is wrong because sliding fee scales by definition vary by income level. A flat fee charged equally to everyone would not be a sliding scale and would not meet federally qualified health center requirements for income-based discounting of charges. C is wrong because free care without any review is not how sliding scales operate at federally qualified health centers. Even nominal fees may apply at the deepest discount tier, and documentation of income is part of the eligibility determination process. D is wrong because sliding fee scales help underinsured patients as well as uninsured patients at federally qualified health centers. Eligibility is based on household income relative to the federal poverty level rather than on whether the patient has insurance coverage. Federally qualified health centers, or FQHCs, receive federal funding under Section 330 to serve medically underserved communities. By law, they must offer a sliding fee scale, adjusting what a patient pays based on income relative to the federal poverty level. This program exists because access to primary care drives population health, and unaffordable bills scare low-income patients away entirely. The sliding fee scale prevents that single visit from becoming years of medical debt. The mechanism is simple. The patient brings income documentation. Staff calculate income against the federal poverty level for their household size, and the posted scale assigns a discount tier. The patient pays that tiered amount, while the federal grant covers the rest, with annual reapplication or reassessment if income changes. Remember, eligibility is based on income, not insurance status. Uninsured and underinsured patients both qualify. Don't confuse this with hospital charity care, manufacturer patient assistance programs, or Medicaid, each of which follows different rules. When a question mentions FQHC, federal poverty level, or fees based on income, think sliding fee scale, a tiered, income-driven structure unique to that clinic. Question 48. A patient asks about long flights and clot risk. The medical assistant should identify which classic triad describes the contributors to deep vein thrombosis. Your options are A. Cushing triad, B. Beck triad, C. Charcot triad, D. Virchow triad. Got a guess? Lock it in. The correct answer is D. Virchow triad. D is correct because Virchow triad describes the three contributors to thrombosis, namely venous stasis, hypercoagulability, and endothelial injury. Long flights produce stasis, which combines with other risks to cause deep vein thrombosis in patients. A is wrong because Cushing triad describes hypertension, bradycardia, and irregular respiration seen with rising intracranial pressure, so it does not describe the three contributors to deep venous thrombosis formation after prolonged immobility on flights. B is wrong because Beck triad describes hypotension, muffled heart sounds, and jugular venous distension seen with cardiac tamponade, so it does not describe the three contributors to deep venous clot formation after immobility. C is wrong because Charcot triad describes fever, jaundice, and right upper quadrant pain seen with ascending cholangitis, so it does not describe the three contributors to deep venous clot formation after prolonged immobility. Virchow triad names the three classic contributors to venous thrombosis, and when two or three stack together in one patient, the risk of a deep vein thrombosis or pulmonary embolism climbs sharply. Venous stasis means blood pools instead of moving from long flights, bed rest, or cast. Hypercoagulability means blood clots too easily, from factor V Leiden, oral contraceptives, pregnancy, or cancer. Endothelial injury means the vein lining is damaged by trauma, surgery, or a catheter, exposing tissue that triggers platelets. Picture the vein wall itself, slow pooling blood, a torn lining exposing tissue, and platelets primed to clump. Where these three forces overlap, a thrombus forms. Exams love to sprinkle in look-alike triads. Cushing triad signals rising intracranial pressure, Beck triad signals cardiac tamponade, and Charcot triad signals ascending cholangitis. So anchor each triad firmly to its own disease. Whenever a stem clusters three risk factors around a venous clot, think Virchow triad, and use it to guide prevention like compression stockings, movement, and prophylactic anticoagulation. Question 49. A medical assistant accidentally splashes chemical disinfectant into one eye while pouring it into a labeled bottle. What should the medical assistant do first? Your options are A. Cover the eye with a clean dressing, B. Rinse at the eye wash station for several minutes, C. Instill saline drops and wait for symptoms, D. Drive to urgent care without flushing. Which one is it? Pause the video if you need more time. The correct answer is B. Rinse at the eye wash station for several minutes. B is correct because OSHA-required eye wash stations deliver continuous flushing for at least 15 minutes after a chemical splash. Flushing dilutes and removes the agent before reporting or provider evaluation, since tissue injury accumulates each second of contact. A is wrong because covering the eye traps the chemical against the cornea and prevents the dilution that flushing achieves in those critical first minutes when injury is most actively occurring at the eye surface during exposure. C is wrong because a few drops of saline cannot adequately dilute a splash, and waiting for symptoms allows ongoing tissue damage from continued chemical contact. that flushing would have prevented upfront entirely now today. D is wrong because leaving without flushing prolongs corneal exposure, and any car ride wastes the most important window for limiting chemical eye injury and preserving the patient's long-term vision in the affected eye permanently. When a corrosive chemical hits the eye, every second determines whether vision survives. The response is not covering, waiting, or driving somewhere else. It is immediate, sustained flushing at an eye wash station. OSHA requires an eye wash station within 10 seconds of unobstructed travel from any chemical hazard. It must deliver tepid, potable water to both eyes at once and allow 15 minutes of continuous flushing without the user holding a valve open. And plumbed units are tested weekly to confirm they work. Effective flushing depends on volume, time, and angle. The worker leans into the station, holds the eyelids open, and lets water flow from the nasal side outward to carry debris away from the tear duct, removing contact lenses if they haven't already washed free. Acidic agents coagulate proteins on contact, while alkaline agents penetrate deeper and keep burning for hours if not diluted. Disinfectants used in clinical settings can cause serious corneal injury too, and a quick rinse at the sink never achieves the dilution that sustained eye wash flushing does. Covering the eye, instilling drops, or driving to urgent care all waste the irreplaceable first minutes when chemical concentration is highest. The exam takeaway for any chemical splash to the eye: flush at the eye wash station for at least 15 minutes before any other action. Question 50. A hospice patient asks the medical assistant what to expect physically as her condition advances. Which of the following sets of findings fits approaching death? Your options are A. Increased appetite and bright eyes. B. Steady weight gain and warm extremities. C. Mottled skin and Cheney-Stokes breathing. D. Energetic restlessness and clear urine. Take a second. Which answer would you pick? The correct answer is C. Mottled skin and Cheney-Stokes breathing. C is correct because approaching death often brings cool, mottled extremities, Cheney-Stokes respirations, the death rattle, decreased urine output, and increased sleep with withdrawal. Recognizing these signs prepares families and supports comfort-focused care during the final phase of life. A is wrong because increased appetite and bright eyes describe a healthy, energetic state, which contradicts the late-stage hospice findings expected as the body slows down at the end of life when systems gradually shut down despite supportive care. B is wrong because steady weight gain and warm extremities describe wellness and growth rather than the cooling extremities and weight loss seen at end of life, so it does not align with typical signs clinicians watch for during final hospice weeks. D is wrong because energetic restlessness with clear urine mixes a real symptom of restlessness with inaccurate findings. Since terminal restlessness occurs, but urine output decreases sharply rather than remaining clear during the final phase of life today. In the final hours to days of life, the body follows a recognizable pattern of physical changes. Hospice teams teach families about these signs so they can find comfort instead of fear. The classic cluster includes cool, mottled skin, irregular Cheney-Stokes breathing, the death rattle from pooled secretions, decreased urine output, and increased sleep progressing to unresponsiveness. Exam stems combine these findings together as the correct end-of-life pattern. Each finding traces back to physiologic shutdown. Falling cardiac output centralizes blood flow, causing cool mottled skin. A less responsive brainstem creates Cheney-Stokes breathing. Lost airway strained pool secretions into the death rattle, and reduced kidney and brain activity explain decreased urine and increased sleep. A daughter hearing her father's wet breathing may fear he's drowning, but the death rattle typically doesn't distress the patient and is managed with gentle repositioning, not suctioning, Recognizing these signs as normal rather than emergencies is the key exam and clinical takeaway. Anticipatory guidance helps families witness mottling, irregular breathing, and gurgling with understanding instead of alarm. Knowing hospice support is always available. That wraps up our CCMA question and answer session for today. If you'd like more practice with what we covered, visit our website using the link below. There, you'll find hundreds of free practice questions plus detailed study guides on every topic we discussed today. Everything you need is ready and waiting, so go check it out and keep learning. Subscribe so you don't miss the next part, and good luck on your exam.